Good afternoon, everybody. Dr. Michael Jacobs here at the Fertility and IVF Center in Miami, wishing you a great Monday afternoon. And today's topic of discussion is embryo batching. What is it, and is this something that we should consider? Embryo batching is a concept that occurs with in vitro fertilization. And just to a short review of that, with in vitro fertilization is one of the most common treatments for infertility patients, where you're stimulating the woman with fertility drugs to produce a multiple of eggs. The eggs are removed from the ovary, fertilized with sperm in the dish, and the embryo is allowed to develop for 5 to 6 days in culture. At that point, embryos can either be transferred directly into the uterus, or as most patients elect, to undergo what's called pre-implantation genetic testing for aneuploidy to make sure they're genetically competent, and then cryopreserved before considering transferring them back. So in any couple undergoing a cycle of treatment, at the end of the day in the IVF cycle, we're going to have some embryos available. And the number of embryos available, and for conversation, let's assume we're doing embryo biopsies, so we know that they are embryos that have developed to a good stage of development and embryos that are competent so they could potentially work in the uterus. And these are embryos that theoretically can result in a pregnancy. And what we know, whether a woman is 30 years old or even 42 or 43 years old or even 45 years old, as long as we have a normal embryo and we're putting it into a normal uterus, a normal embryo meaning one that developed to the blastocyst stage and from a genetic standpoint has the correct number of chromosomes. If we put a normal embryo into a normal uterus, the expectation would be that 50% of the time that embryo is going to continue to develop and more than likely result in a baby. Miscarriage rates with genetically competent embryos are usually no more than 10%. So if we use the 50% rule as just a way of thinking about things, in any cycle that we put an embryo in, we've got a 50% chance that it's going to work and a 50% chance that it's not going to work. So if we go, well, how many embryos do we need in order to get a pregnancy? Obviously, in half the patients, we only need one embryo because they'll get pregnant the first time. But some of the patients won't get pregnant the first time. So it's nice to have an extra embryo available. And if you transfer that embryo is still only going to have a 50% chance of working. Remember, each time you put an embryo in, we're getting that 50% chance of implantation and continued embryo development. So it's not that, okay, you have 2 embryos in the first cycle, it worked, and that means that when you go use the other embryo, it's not going to work, and vice versa. If the first embryo didn't work, doesn't mean the embryo that we didn't transfer is going to work. Each time you do it, you have a 50% chance of it working. So if you have one embryo, we do a transfer, it's 50%. If you have 2 embryos and we put one back and it didn't work, and then we put another back, half the people would have gotten pregnant initially, and the other half of those would get pregnant with the second embryo transfer. So with 2 embryo transfers, you have about 75% of people getting pregnant. And you can keep going with this, and then if you took the patients who still didn't get pregnant, you did a 3rd embryo transfer, half of those would get pregnant. So after 3 cycles, you have about 87-90% of people getting pregnant from 3 embryos. So in general, my own thought process in talking to patients is that if we have 3 normal embryos that are good quality, that are cryopreserved or available for transfer, then in most of those patients, and almost 90% of them, we're going to end up with a baby at the end of the day. So in my mind, 3 embryos is a minimum amount that one needs to think about having a baby. So what does embryo batching mean? It means that if we get to the point of we have some embryos and now we're going to plan what to do with them, and we're going to try and plan an embryo transfer cycle, Batching refers to the concept that prior to transferring an embryo back into the uterus, we do another cycle of stimulation. We go get more eggs. We go produce more embryos with the idea of batching them so we have more of them available in the freezer for future use. Now, when is this advantageous? It's advantageous in somebody who's young, who is, well, let's reverse that. Embryo batching is most advantageous when you have somebody who's older, where there are concerns of diminished ovarian reserve and this desire for more than one child. So if you have a couple that the game plan is, we want one baby, we're positive of that, and it's all we want, then it doesn't really make a difference if you're 25 or 35 or 42. Even if we only have one embryo available for transfer, if you only want one child, our recommendation is let's put that embryo back and see what happens. Now, let's say a couple has one or two embryos available, and they want to have more than one child. They want to have two children, and they don't have any yet, so they're doing IVF to get pregnant, and we now have two embryos. We still recommend transferring one at a time, doing a single embryo transfer, because that's the safest pregnancy. It's the best outcome. We put an embryo back. If it works, great. If it doesn't work, we put another embryo back. Let's assume one of them works. Patient is now pregnant. 9 months later, they're going to have a baby. Then you're going to either breastfeed or bottle feed for a short period of time, and you need to give the uterus a good 6 months before it's ready to be pregnant again. So the practical side is, if you get pregnant in now, whether it's spontaneously or with an IVF cycle, you're really not going to be ready to get pregnant again for another 18 months. So in a couple that's young, who has good ovarian reserve, nothing wrong with the uterus, no anticipation of a problem, and they desire multiple children, but they just needed IVF to get pregnant for whatever reason, whether it's sperm problem, tubal problem, unexplained infertility, we're doing IVF to get you pregnant. Odds are we'll need to do that again in the future. We do IVF, you get pregnant, there's no embryos left over, and then 2 or 3 years you come back and now you're 31 or 32 and you want to get pregnant again. More than likely it's going to be the same routine over again. We're not going to have any major issues other than needing to do the IVF. But let's say you're a young person with diminished ovarian reserve, or you're a woman who's 40 years old, and you go, we've got 2 embryos to work with, and you absolutely want at least 2 children. 2 children is what we like. Well, then the concern is, if you're 40 and we put an embryo back and you get pregnant, you're not going to be ready to get pregnant again until you're 42. And we know that as you get older, both the ovarian response to medications, the higher incidence of formation of abnormal embryos, of aneuploidy, keeps going up. So it's going to be much, much more difficult at 42 getting you pregnant compared to 40, and certainly more and more difficult the older you get beyond that, 43, 44 compared to 40 or 41. So the concern is that if you only have one embryo, let's say you have 2 embryos and we put one back, you get pregnant, now you're 42 or 43, whatever the case may be, or if you're even 32 but you have a very significantly compromised ovary for whatever reason, and you have diminished ovarian reserve, you're now going to be a few years older when we're ready to stimulate you again, and you might not respond as well as you did the first time. So we might not have normal embryos available. So one of the advantages of batching embryos is the concept that we're getting more to store for later use. So let's go back to that example, the 44 and a half year old person, we put 1 embryo in, they get pregnant, they now come back 2 years later, they're 42 plus, and they want to get pregnant a second time. Obviously, if we have an embryo available, that's what we would transfer. Now they're not pregnant, now we have to start all over again. But if we had batched embryos at age 39 or even earlier, before getting you pregnant, we would have more embryos available to use, so that if you didn't get pregnant with the first frozen embryo, we'd have others to use thereafter. And a good rule of thumb to me is having at least 3 embryos available for each baby that you desire. Obviously, 4 is better than 3 and 3 is better than 2, but 3 is a reasonable number per baby that you so desire. None of our statistical projections can guarantee that it's going to work, and so it's always good to have more rather than less. But in general, a good rule of thumb is at least 3 normal genetically biopsied embryos for that. So what happens when you get older? Ovaries tend not to respond as well. When you have diminished ovarian reserve, they tend not to respond as well. So you're producing less eggs. When we go to fertilize those eggs, it results in less embryos being produced. When we biopsy those embryos, because of the increased age, there's a higher natural incidence of aneuploidy being pregnant, so we have less normal embryos available. So we usually are going to get a better response earlier than later in the number of good quality embryos that we're going to end up with. So embryo batching becomes very valuable in any couple who desires more than one child when they have a limited number of embryos available prior to the embryo transfer. In a younger person with good ovarian reserve, it doesn't really make a big difference, and it doesn't make a lot of sense to embryo batch unless there are other concerns going on. Those concerns could be BRCA mutation testing, a need for prophylactic oophorectomy. It can be the suggestion of uterine abnormalities or endometriosis that's very severe, that's involving the muscle layer, adenomyosis. Things that might affect success down the road would include both the quality of the eggs and the stimulation, as well as the environment of the uterus to put the embryos in. So, and in those particular patients that have a history of recurrent miscarriage, or some reason to have a less than ideal implantation outcome or less than ideal ongoing pregnancy expectations, in those patients having more embryos available before doing a second transfer is logical. So in brief summary, embryo batching is the concept of creating more embryos before transferring an embryo and getting pregnant. The reason you're doing it is for fertility preservation. It's basically taking the treatment of infertility one step further. So not only do we want to treat you to get you pregnant now, but we want to think down the road to preserve your fertility for your future child, whether it's number 2 or number 3 or whatever your personal desire is. So we both want to get you pregnant by treating your fertility, as well as trying to preserve fertility for the future. Batching is best in women that have diminished ovarian reserve, in women that are older, even with good ovarian reserve, and in general, you want to have at least 3 good quality embryos available for potential transfer in for each child that you each might like. So if you say, hey, I want 3 kids and I want to make sure I'm going to be able to get pregnant down the road, then you'd like to have at least 6, preferably 8 or 9 embryos. With 3 kids, you'd want at least 9 embryos and even a couple more. And that would require multiple cycles of treatment unless your ovary was extremely sensitive. And if your ovary was very sensitive and you're producing a lot of embryos, then you don't need to embryo batch. So it's just a thought that a conversation that you should have with your doctor when you're talking about embryo transfer. Do I need to batch embryos? Do I not need to batch them? If you have good ovarian reserve and you're young, you don't. If you have poor ovarian reserve or are older and you desire more than one child, it's certainly something to consider doing. So I hope that was helpful and not too confusing. Please feel free to ask any of us any questions you have on it. We wish you all well and success with your treatment. We always try and get it to work the first time, but we do realize that nature has its limitations, and we need to think along those lines to both get you pregnant now and preserve your fertility for the future. So have a good afternoon, everybody. Wish you all well.